Hey, CEimpact subscribers. Welcome to the GameChangers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. Antibiotic resistance continues to dominate headlines as new data highlights its growing threat to global health. In this episode, we'll discuss the latest updates in antimicrobial stewardship, recent advancements in combating resistance, and how pharmacists can stay at the forefront of preserving the effectiveness of these critical therapies. It's so great to have Geoff Wall with us as our guest expert for today's episode. Welcome, Geoff.
Hello.
Yeah.
Thank you.
Most of you, if you are longtime listeners of GameChangers, Geoff is no new person for you. He has been a mainstay on the podcast for several years, and we're so excited to have Geoff back with us today. But just in case we do have some new listeners, Geoff, go ahead and tell us a little bit about yourself, maybe your practice side and things
Sure.
you're passionate about in the topic of pharma.
Sounds good.
Yeah.
No, we were lucky enough that I was actually one of the first people on board with the podcast. So yeah, it's hard to believe it's been 4 or 5 years now.
This is our sixth season, so yeah, lots of
season, unbelievable. Geoff Wall. I'm a professor of pharmacy practice at Drake University in Des Moines, Iowa. I'm also an internal medicine clinical pharmacist at Iowa Methodist Medical Center, also in Des Moines, and I'm also director of the Drake Drug Information Center as well. So kind of wear a lot of hats. My practice is mostly internal medicine and critical care at Methodist Hospital, which is a large community-based tertiary care center teaching hospital. And been at this a long time, and still love what I do, and love seeing different things and stuff. So and since the two pillars of internal medicine are largely considered to be cardiology and infectious diseases, I deal with ID stuff pretty much every day.
Awesome. Well, and again, as I mentioned, Geoff is not just an expert in this particular topic. He is an expert in several topics, given his background and critical care. So we greatly appreciate you taking your time out this morning to join us. So, all right. So I love to just jump right in. So let's go ahead and jump in. So I want to kind of talk a little bit about I always like to bring foundational level for the listeners. So let's just briefly talk about antibiotic resistance in general. What
Sure.
really is it? What's the cause of it? What's the impact of it? So I'll give you kind of the floor to touch on that for a little bit.
Sure. Well, I mean, I think everybody has kind of an operational definition of antibiotic resistance, where standard antibiotics that have long worked against and reached clinical cure of an infection just don't seem to do that anymore. And it's not a new phenomenon. When I teach bugs and drugs to my students, I often mention to them that penicillin came out, plain old Pen G came out in the 1950s, and when it first came out on the market, it killed everything. It was this incredibly powerful tool, if you read medical literature of that era, if you read, New England Journal of Medicine and stuff in the 1950s, they're like, is there anything penicillin doesn't work against? This is incredible. Well, of course, very rapidly, we started to realize that, the bugs always win is a phrase I always use. And, eventually, evolutionarily, bugs will always find a way to become resistant to any antibiotic you throw at them. So, when penicillin was a mainstay for almost every infection in the 1950s and early 1960s, here in the 21st century, we, for the pharmacist in the audience, when's the last time you filled a prescription for plain old penicillin BK? I mean, we just don't use it anymore because of the element resistance. And so, the development of antibiotics in the last 80 years has really tried for us to kind of stay one step ahead of resistance. And until about 2000, I think we had done a pretty good job of that. But in the 1990s and 2000, we started to see the rapid increase of resistance, particularly to gram-negative organisms like E. coli and Klebsiella and stuff like that, and it's very regional. If you're in certain regions, you have terrible resistance. If you're in other areas, you have no resistance. So it really is kind of a regional thing. But that has now led to entire groups of organisms which are resistant to vast swaths of antibacterials. And so we're forced either to have antibiotic failure, which of course isn't good, or to use very, very expensive antibiotics. And it's important to remember that the pipeline for antibiotics is not inexhaustible. We've run out of kind of low hanging fruit to come up with new antibiotics. And frankly, there's no financial incentive for drug companies to come up with new antibiotics, right? I mean, if you're the head of R&D of a major drug company, what would you rather spend your money on? Another drug for hyperlipidemia that people are going to take for the rest of their life, or an antibiotic that hardly anybody's going to take, and when they do take it, it's for 10 days. And so there's very little financial incentive for drug companies to do innovation in this area, and that's worth noting. And so antimicrobial resistance is a huge global health threat. It's responsible for about 1 million deaths globally a year, and that's not, in our world, in the United States, probably a little bit less than that. But I mean, now we're talking mostly about, super drug resistant tuberculosis and stuff like that, which is now very common in other parts of the world. There's a huge economic impact, and it's estimated that, that costs of antimicrobial resistance could lead into the trillions of dollars worldwide, by the end of 2050. So, this is just, it's a very expensive problem. It's a problem that's going to lead to deaths. It's a problem that's going to lead to other issues. Wow. So it's just, it's a big problem.
Yeah, it's definitely a big issue. I mean, that number, that number is staggering to me, the 1 million deaths a year. Like I would have never come close to guessing that number if you'd said, how many do you think die because of that? So, wow. Right. So one thing I'd like to also point out is sometimes therapies and guidelines change based on the new data we have, regarding antibiotic resistance or anything like that. One of recent was H. pylori treatment. Can you speak on that just briefly?
So H. pylori is I mean, you could write an entire book. I wish somebody would, about H. pylori, because remember that this was a bug that was discovered in the 1980s by the Australian researcher Barry Marshall. And it's it's almost kind of an apocryphal story of how, he, left some stomach tissue, went on vacation, came back. There was a whole bunch of bugs on it. He thought it was a contaminant, but he kept growing it. So, and he tried to convince people that was the cause of peptic ulcers. No one believed him. So he drank a bottle of H. pylori and gave himself an ulcer, and then figured out the antibiotics to treat it. I mean,
wow. I've never heard that story. That's fascinating.
Yeah. It's almost an apocryphal story, but it's true. And he actually won the Nobel Prize for it. But the problem with H. pylori is that it is a hard bug to kill, which makes sense. It lives in your stomach, which has a pH of 3, right? So, I mean, it would eat away my skin, because, you're essentially got one normal hydrochloric acid in your stomach. So, I mean, it would essentially burn my skin, and it's able to thrive in this low oxygen, high acid environment. And so because of that, you need multiple antibiotics to eradicate it. And the problem with looking up the research of how to treat H. pylori becomes very dicey, because the global resistance rates are unbelievably different from one country to another. Some countries have had very bad resistance issues for decades, whereas others have not. And the United States, fortunately, up until about 4 or 5 years ago, had not. We were still using, the amoxicillin, clarithromycin, proton pump inhibitor-based therapy that I'm sure all the pharmacists out there and physicians and nurses are well, very, very familiar with, right? And we have been using that for almost 30 years for the treatment of H. pylori, whereas in other parts of the world, they had abandoned it decades ago because there was too much resistance. And we finally reached the point here in 2018, 2019, where United States resistance rates, particularly to clarithromycin, had now surpassed 20%. And so unfortunately, the amoxicillin-based regimen that I'm sure we've all filled a million times, we have memorized and all that stuff, just wasn't going to work in a significant minority of patients. And so in the new set of guidelines that came out from the American College of Gastroenterology, they said, sorry, it's time to go to a bismuth-based regimen. And so that is now the recommended regimen, which unfortunately for patients is a real pain, right? Because it's you have to take, the medication 4 times a day. Nobody's going to remember to take a medication correctly 4 times a day. And it's, four drugs, and it's a real pain. And, at the DI center, we've certainly run into issues from our physicians who are like, okay, I heard we can't use amoxicillin-based regimens anymore. Like, nope. Okay, well, my patient is, they can't take, metronidazole, or can't take tetracycline. Now what do I do? And it's multiplied the difficulty of treating H. pylori significantly, and it goes beyond just curing ulcers. I mean, obviously that's a big thing, but remember that H. pylori is also a big player in certain types of gastric cancer. So, I mean, once you've detected it, you pretty much have to treat it.
Right. Yeah. Got to get rid of it. Yeah. 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 That's, that's, I mean, I am coming up on a milestone anniversary this year of 20 years from graduating from pharmacy school. And I remember the original pack. I won't call the brand name of it, but I remember the original pack that was used back in the day for H. pylori.
Yep,
So,
absolutely.
yeah.
Yep, absolutely.
Yep. So it's interesting to see how, it was still kind of the mainstay until just recently. So that's kind of
Right.
wild.
Yeah. No, I mean, we've certainly been lucky, I
Yeah.
think, I mean, but, I think infectious disease experts knew that sooner
It
or
was
later,
coming. Yeah.
it was
Yeah,
coming.
for sure.
So.
Well, let's kind of roll into, again, that was kind of the impetus for the discussion for today, was to kind of let's bring focus to antibiotic resistance and stewardship and whatnot. So let's kind of segue into the role of antimicrobial stewardship. But first, let's define what that means. What is stewardship, and what are kind of the overarching goals for that?
I mean, the Infectious Disease Society of America has an official definition, but I think if you talk to most ID practitioners and ID pharmacists, they'll tell you that really stewardship is basically making sure that we use the right antibiotic for the right length of time for the right patient. That minimizes cost, that minimizes resistance, and that minimizes side effects, right?
Mm-hmm.
And you can practice, and I think a lot of pharmacists do practice stewardship at the patient level, right? Okay, well, just today on rounds, I had a patient who was on piperacillin tazobactam for something that they absolutely did not need that powerful of an antibiotic for, so we were able to de-escalate to ceftriaxone. So that's a patient level, simple, that I suspect pharmacists do every day, right? But you can also practice stewardship initiatives at the population level or at the system level. And that's, I think, where a lot of ID physicians and ID pharmacists really find themselves at that crossroads where, they're working with individual patients, but they're also trying to set up systems so that appropriate antibiotics are selected more frequently than inappropriate antibiotics are, right? Yeah. And a good example of that would be, a lot of hospitals have for urinary tract isolates, for urine isolates, have intentionally not reported quinolone susceptibilities on their, for example, E. coli. And they're doing that not to harm patients or anything, but that it frankly is, and studies have shown this, is that physicians are less likely to pick quinolones if it's not on the susceptibility report, right? And since we don't want to use quinolones unless we absolutely have to because of the myriad adverse effects associated with them, that's an example of a system antimicrobial stewardship initiative that has largely been pretty successful.
Yeah. Wow. That's great. What is the pharmacist's unique position? You kind of touched on it, but I think, obviously antimicrobial stewardship and combating resistance to antibiotics is a multi-team effort, interdisciplinary, and lots of people have to be involved. But what specifically is the pharmacist's unique position? Like, how can we position ourselves to really interact and to make a difference?
Right. I think one of the big kind of low-hanging fruit for community-based pharmacists and hospital pharmacists is to clarify and assess antibiotic allergy. Someone says they're allergic to penicillin, that forces the prescriber to pick something they would never normally pick, that is more expensive, that has more side effects, that is more likely to cause resistance, right? So, if you get a community-based pharmacist gets a prescription for linezolid orally, in addition to it being hundreds of dollars, and looks at the patient's profile and says, "Oh, you're allergic to penicillin. What happens when you took penicillin?" "Well, I got a rash when I was 6, and now I'm 80." Okay, well, there's a pretty good chance you're not actually allergic to penicillin anymore. We can pick a cephalosporin that would work just as well. So let me call the physician and let them know that, not only is linezolid unbelievably expensive and has side effects, but it's going to increase the risk of resistance down the road. we can pick, Keflex or cephalexin and it will work just as fine,
Mm-hmm.
sort of thing. So I think that's a pretty low hanging fruit, because I think many prescribers are just not up to date on what the latest information is on antibiotic allergy. So I think that's one way. And then I think all sorts of other ways, whether you're in the community or the hospital. In the hospital, we have a formulary where if some unusual antibiotic is selected, we can that kind of a red flag for us and say, okay, no, why, is there a reason why you picked this antibiotic particularly? If it's not appropriate, yeah, exactly. If it's not appropriate, we can maybe, come up with another option for you and stuff like that. So again, I think community and hospital-based pharmacists I work mostly at the patient level. And I think that they, since they know the costs, they know the side effects of the drugs pretty well. I think that they play a really good role at that patient level of saying, okay, this is a pretty unusual antibiotic for this infection. Let me do some more digging and figure out, is this the right choice, basically.
Yeah. Well, and I'll take a question a step further in that role. So that makes perfect sense, and I agree with that. I know that there are some out there that may struggle with the courage to reach out to the prescriber and say, "Hey, what about this?" Do you have any tips or tricks to kind of share with our pharmacist listeners on that?
It's always the problem, right? Or you're never going to get through to the doctor. You're going to get through to the front staff, secretary who, her automatic response is, the doctor wrote it that way, just fill it, sort of thing, which I know drives my community colleagues, up a wall, as it should. I think, the best way to approach that sort of stuff is, always to have the information, readily available. And, the Infectious Disease Society of America has guidelines for just about every infectious disease. So there's very, very few infectious diseases out there that IDSA doesn't have official guidelines on. And that would be my first shop stop. So, someone comes in with a weird antibiotic and you're like, okay, well, first up, I'm not even sure I have this. Second, if I do, it's going to be really expensive. Insurance probably ain't going to pay for it. But before I start going through all that rigmarole, let me do some investigation. Okay, no, actually, I think we could pick this antibiotic. And then I think, leaving a message, because that's probably what's going to happen. You're rarely going to get the prescriber on the phone, and just say, look, IDSA basically says that this is the correct, this is the right antibiotic. I see the patient had an allergy to X, we could certainly use Y, and that would be in the IDSA guidelines too, sort of thing. I think that you're never going to get 100%, but I think that you're far more likely to get your recommendations accepted both in a hospital and a community when you've got the guidelines on your side, or you've got the evidence on your side.
No, that's great feedback, and that's great advice too, because, I think a lot of times pharmacists, they have the knowledge, they have the they have the know-how and the power and whatever, and they've probably done that research, but sometimes it's the communication, that just making sure that you're giving it to the prescriber in the way in which they're going to receive it, positively. And so I think it's good feedback to say, go in there with the guidelines first and foremost, because that's really what's going to speak to the prescriber. So,
And for the IDSA guidelines, they're completely free. They're on the idsociety.org website. Maybe you have that bookmarked on your computer at work, and whenever you need it, pull them down.
Absolutely. Yeah. And I think that, we always try to talk about ways too that pharmacists can utilize, pharmacists can utilize their team members on their team to kind of help with that too. And so I think you talking about the allergies and really digging deeper to find out if they're true allergies, that can be kind of a triage point for the technicians and other staff members to say, are you allergic to anything, whatever, and get some more information to pull the pharmacist in for that discussion. So,
exactly.
Great. Okay, so let's talk a little bit about some opportunities and challenges that our pharmacists are likely going to face as they try to go through, assisting with antibiotic resistance at whatever level, like you said, whether they're community-based or hospital-based, or in a consulting role in a long-term care or whatever. What are some of the opportunities, obviously, that we have, of course, to reduce resistance rates? But how does that actually, how are our efforts actually going to reduce resistance rates? Kind of make the connection for us.
It makes it tough because, of course, resistance is a global phenomenon, right? I mean, of course, it's a patient level phenomenon, but it happens because of a change in ecosystem. It happens because of a change in what's going on with the bug itself. And so, it's always been a challenge to study this at the patient level because you'll do the right thing and spend, 6 months making, 100 interventions on patients to optimize, stewardship and optimize antibiotic regimens. It's going to be very hard to study that. So did that 100 lead to a decrease in resistance, and how are you going to measure that and sort of stuff? So I think when you're looking at this, you have to look a little bit less at the, if I, keep doing this, I'm going to see, the community around me is going to see less resistance. Sure. I think that's true, but I think it's going to be very difficult to measure that. And so I think, I think what you do is you say to yourself, okay, Mrs. Smith, this is her second urinary tract infection this year. I know she gets them several times a year. Sooner or later, if we keep using big gun antibiotics on her, the E. coli she's inevitably going to grow is going to be resistant to everything we throw at it. And now we're going to have to admit her to the hospital for IV antibiotics or an infusion center or something along those lines. So I think that unfortunately systematically studying stewardship responses at a system level has always been challenging. And so I think for the individual practitioner, you just have to kind of say, yes, I'm doing this for the system, but I'm really doing it for this patient in front of me, because patients who get infections tend to get more infections, right? For whatever reason, right? You're a Foley catheter, so you're going to get lots of UTIs. You've got bronchiectasis, you're going to get lots of pneumonias. I mean, things along those lines. And so, every antibiotic course they get puts them one step closer to developing a resistant organism. So I think that's one of the ways you approach it. And then the other, of course, is just education. Just recently, the IDSA had come out with a new set of guidelines for treatment of resistant gram-negative organisms. And if you work, especially in a hospital setting, there's some big changes in this, and it has fundamentally changed my recommendations. And I think should be read by just about every pharmacist who dispense or recommends antibiotics. Some of the big paradigms that we had kind of hung our hat on. Probably one big example is extended spectrum metallactamase E. coli is getting to be pretty common even here in Iowa. I mean, we've been in the center of the country. We've dodged a lot of the, oh my God, terrible resistance, that colleagues of mine on both coasts commonly deal with. Right. I'll talk to them and I'm like, wow, yeah, I haven't seen one of those. And, with luck, I won't, but even here in Iowa, we've seen a real spike in extended spectrum metallactamase E. coli. Well, that becomes a real problem because previous to the set of guidelines, the standard of care was unfortunately to use parenteral carbapenems on these patients, which meant they had to come in and get an IV placed and get IV stuff, and it was a pain, and it was hard to do and stuff. Oh no, the new set of guidelines say, no, actually, there's evidence now that shows that for just cystitis, just for bladder infections, that nitrofurantoin and Bactrim often work against E. coli, ESBL E. coli. So if just for cystitis, not for bacteremia or anything, it's reasonable to do. So again, how's the pharmacist get involved with that? They know the guidelines. And when they see an order for outpatient, ertapenem, they can go and say, well, actually, here's what the brand new guidelines say is okay if we went to nitrofurantoin on this patient. So I think it's not like that.
So what I'm hearing, to summarize, is it's important and it's key for the pharmacist to be sure that they're updated on the guidelines, obviously. And another thing is to realize that you're not really going to be able to necessarily quantify something. So you can't say for every 2 antibiotics I change, I'm going to save this many dollars for the whole economic system, whatever. So it's more of a global community effect. And like you said, I love the idea of focusing on that patient. Like, I'm really making this change for this patient because A, B, C, D down the road is going to be harder for them if we don't do this now. So yeah, that's great. Okay, so let's talk then about some of the challenges before we run out of time. So obviously with everything that we do, there are challenges and barriers that we have to overcome. So what are some of those common ones that we're going to see when we're trying to implement resistance and stewardship?
I mean, I think, for pharmacists and I think for ID physicians too, I think that the territoriality of physicians and providers who are like, no, I'm the person in charge of this patient.
Sure.
By God, this is what I'm going to prescribe. Sure. I think that has largely faded. Yes, the God complex with physicians is sometimes alive and well, but in my 34 years now being a pharmacist, I've seen it much. Most physicians are trained in a team-based situation. I think they're far more likely to listen to pharmacists than when I came out of school.
That's great news.
Right?
Yeah.
Oh yeah, no doubt about it. So I think that's part of, but that's still going to be a challenge. Sure. You're still going to run into providers, and not just physicians. You're going to run into other providers who, feel like this is their territory, or feel like if someone asks them to change something, then they're wrong.
Right. They made a mistake.
They made a mistake. And I think it's important to say, look, in so many areas of medicine, but in ID in particular, there are a million ways to skin a cat, right? I mean, there's lots of antibiotics that would theoretically work for X infection. And so, I think you have to say, look, what you did wasn't wrong. Mm-hmm. It just isn't the most optimum way to deal with this. And if we don't use the most optimum way to deal with this, again, to your point, this is where we're going to see side effects. Mm-hmm. This is where we're going to see more resistance, et cetera, right? So I think that's a challenge. I think for community pharmacists in particular, not having local antibiotic resistance patterns at their hand is really difficult. In the hospitals, we do antibiograms where we have the ability for our, to take a look at, this last year, we've looked at all the E. coli organisms that we have grown, and globally, what's the resistance rate to Bactrim? Globally, what's the resistance rate to nitrofurantoin? We have that information, and I can use that information. I wish, and I know my colleague, Andy Meisner, he's a colleague of mine at Drake, and he's a community pharmacist or a clinical pharmacist at one of the neighboring hospitals in town. He's actually done a lot of work in this city trying to come up with kind of a global community antibiogram that can be put in the hands of community pharmacists, because I think that's important. Yeah. And, because, and I mean, I'm sure he's much more of a tech whiz than me being an old man, but I think he's, he realizes also that needs to be, integrated into the software that all pharmacists use, right? So when an antibiotic pops up, and you're entering an antibiotic into your computer system, you can just hit a button and it pops up and says, okay, for E. coli in this city, Bactrim resistance rates are X. Okay, well, that's pretty good, or it's terrible, or whatever, right? Excuse me. That I think plays a role. So I think having the information at your disposal, not just the IDSA guidelines, but local resistance patterns, is very, very important. And antibiograms have been shown time and time again in the hospital setting to help decrease resistance, because it allows us with confidence to say, you don't need this gigantic big gun antibiotic. Our antibiogram says that 90% of all these bugs that we have had here are susceptible to augment or Bactrim or cephalexin. Nice and easy. This is what we should go with, sort of stuff, right? So I think that's one. I think, unfortunately, I think for both community and hospital pharmacists in particular, who's going to pay, right? Everybody agrees that stewardship is important and the resistance is terrible, but like so many things in the world of pharmacy, nobody's actually willing to put their money where their mouth is, right? Really, we should be paying community pharmacists to do stewardship activities. Mm-hmm. We should be paying hospital pharmacists to do stewardship activities, right? And I think community in particular, when the phone is ringing off the hook and you got 87 people yelling at you and, 57 vaccinations and all that. I mean, the idea of having to do one more thing is just like, forget it. Yeah. And, like all humans, I think we tend to take the path of least resistance, right? It's like, okay, I could call on this linazolid, but
they wrote it, so they must mean that's what they want.
Right, and the insurance is taking it, so the patient's willing to pay for it. So peace out, sort of thing. And so, I mean, I think that if insurance companies, if the federal government or state government would be willing to put some money into this and training into this, I think that community pharmacists in particular could be a force for stewardship like you wouldn't believe. But it's just those things. So I think money, local information, and overcoming some of the territoriality of prescribers.
Yeah, that's great. Well, wildly, as I always say in every episode, I can't believe we're already out of time. It goes by so quickly.
Yes.
So what we always like to do is kind of wrap things back to like, what's the game changer? And clearly, I think the game changer here is that antibiotic resistance is real, and pharmacists have a role in, antibiotic stewardship and trying to combat resistance. But I'd love for you to tell us, like, so I will phrase this a little differently. So typically I ask you to do the game changer, summary, which I just kind of did. But what I want to ask
Right.
you today is, what is the, like, let's give our listeners like one thing that they can do. So you mentioned several of different things that they can do, but like, what's the one thing to kind of take that small step? Because we mentioned they don't
Right.
really have a lot of time or maybe some lack of
Right.
resources. What would you say is the one step to do that our pharmacists can take as our take home today to kind of
Right.
really start helping with stewardship?
I think that the easiest thing is really what kind of started this game changer in the first place. I'm still seeing tons of prescriptions for amoxicillin-based H. pylori regimens. That the memo has not gotten out, I think, to most primary care practitioners. And so I would say if you can do nothing else, you don't have time to do anything else, you don't feel like you have the training to do anything else. I'd say the one thing you can do is every single time a community pharmacist or a hospital pharmacist sees an amoxicillin-based regimen, you just have to know, this isn't the standard of care anymore, right? And so you need to be able to call the office and say, here is, I'm sorry, but unfortunately here is my backup. And if they say, well, I was going to do that, but the patient's allergic to, metronidazole or tetracycline. Okay, well then why don't we do a levofloxacin? Basically, we got to have one or two backup regimens ready to roll on patients. And I think I think that right now, I mean, we could do 2 hours on community-based and hospital-based interventions that pharmacists can do. But right now, that is I think the most important one, because I'm still getting quite a few questions about that through the DI side.
Yeah, that's great. So, that's great. A great tip and great feedback. So, well, as always, Geoff, it's a pleasure. Thank you so much for taking the time.
For having me.
Yeah, we really appreciate you giving your expertise on this topic, as I know it kind of spans multiple practice settings. And it's not just, I think a lot of times we hear antibiotic stewardship and we think of the hospital, but like you've pointed out numerous times today, that's not the case. It spans every practice site. So. Well, thank you again, Geoff. Really appreciate it.
Thank you.
If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dive into another game-changing topic with you all next week.